We are live.
A very good evening to all. And I would like to take this opportunity to welcome all the esteemed chairpersons, panelists, speakers, of course, my co-moderator, and most importantly, the audience for the webinar on walk-in on a patient with neovascular glaucoma. Especially, I would like to again thank the AIOS team, Dr. Santosh Honawar sir and Dr. Manoj Mathur sir, for giving this platform to us. Now, I would like to call upon my co-moderator, Dr. Mona ma'am, to introduce the chairperson and the panelist.
A very good evening to everyone and welcome to the webinar. I'll be sharing my screen for the slides. So it gives me a great pleasure and it's an immense honor to introduce our chairpersons, Dr. Harbanslal, President, All India Ophthalmological Society, Director, Delhi Eye Foundation, Co-Chairman, Department of Ophthalmology, Sir Gangaram Hospital. I also welcome Dr. Harsh Kumar, Padma Shri, Director, Glaucoma Services, Center for Sight. We are honored to have you as a part of the webinar and looking forward to your comments and insights to help us guide to manage this challenging disease. We all know that neovascular glaucoma is a challenging disease, and to meet the challenge, we we have a very eminent set who will give us insights on how to manage neovascular glaucoma. We have Dr. Sushmita Kaushik, ma'am, a professor of ophthalmology, PGI Chandigarh. She has a vast experience in this field and her enthusiasm is infectious. We also welcome Dr. Chandrama Paul, Director and Consultant Cataract and Glaucoma Services, BBI Foundation. Her cool and calm presentation and method of teaching always wins hearts. And of course, we have Dr. Manavdeep Singh sir, Professor of Ophthalmology, Dr. Ram Manohar Lohia Hospital, New Delhi, and the President, Glaucoma Society of India. And we are looking forward to his insights and comments during the webinar. With that, I hand you back over to Dr. Shweta. Stop sharing my screen. Yeah.
Yes.
May I do a minor correction here? I am not the president, but the General Secretary of Glaucoma Society of India.
Sorry. It's my
Not a
mistake.
promotion.
So we are having our presenters here, and I would like to introduce all the eminent speakers who have spared their time despite being a weekend and their busy schedule. So the first presenter with us is Dr. Kavita Srinivasan ma'am, who is a medical consultant, glaucoma services, Arvind Eye Hospital, Pondicherry. Everybody, of course, know ma'am that the way she delivers the lecture and she delivers impart the knowledge about glaucoma. And we are delighted to have Kavita ma'am with us. Over to you, Mona ma'am. Then we can start with the introduction when the speaker, they take the dais. So with that, we start with the presentation for tonight. Over to you, Mona ma'am.
I think I'll request Dr. Kavita to start her presentation, and we're looking forward to it.
Thanks, AOC, Dr. Mona and Dr. Shweta for the kind introduction. So I'm sharing my screen. Hope it is visible. Is my screen
yes, ma'am. It is visible, ma'am, and you are audible.
Okay. So I'll be presenting a case of neovascular glaucoma, a patient who had a post-RD implantation hypotony and its management. My slides are not moving.
IT team, can you please
Yeah.
look into that?
We can't see the slides now.
May you please
So,
share the screen?
yeah, is it visible now?
Yes,
Yeah.
ma'am.
Yeah.
It is.
Yeah, so we had a 69-year-old male patient who was referred to us with a defective vision in his right eye, and he was diagnosed to have high pressures, and he was on anti-glaucoma medications for 3 months. And he also gave history of undergoing cataract surgery 6 months back elsewhere. And he was a known diabetic and hypertensive for almost 20 years. On examination, his best corrected visual acuity was 5/60 and in the right eye, and his intraocular pressure was very high, as shown here. It was 52, and there was a florid neovascularization of the iris and a synovial angle closure in gonioscopy. The fundus view, though, was hazy. There was definitely enlarged cup to disc ratio, but there was no evident diabetic retinopathy. His left eye was quiet with normal vision. So with the above said findings and history, we came to a conclusion of right eye neovascular glaucoma angle closure stage. And we went ahead with the investigations. We did a diabetic profile, complete cardiac workup, and a fundus fluorescent angiography. As shown here, his diabetic status was not under control. Carotid Doppler revealed significant carotid artery stenosis with calcified plaque in both internal carotid artery. In FFA, the features were suggestive of ocular ischemic syndrome. So, as per the routine protocol, he underwent pan-retinal photocoagulation, intravitreal bevacizumab injection, and anti-glaucoma medications. At 6 weeks following the interventions, like his best corrected visual acuity remained at stable at 5/60. However, the intraocular pressure was not getting control. It was 36 millimeters of mercury with maximum possible medical therapy. Hence, with the compromised vision in mind and good vision in the fellow eye, and with very high pressures, we thought of doing a transscleral diode cyclophotocoagulation, which the patient underwent, following which the pressure came down in the immediate few weeks. It was around 22 millimeters of mercury. The vision was stable. However, on further follow-up, almost 6 to 7 weeks following the diode CPC, the pressure again started raising, and it was 36 with maximum possible medical therapy. In order to preserve the existing vision, then we had to do some intervention, and we decided to do orolab aqueous drainage implant. The immediate post-operative period was uneventful. The pressure came down, and he was managed medically following RD with a fixed combination of brimonidine and timolol. At 7 weeks, when the tube opened, again, there was a drastic reduction in the intraocular pressure to 8 millimeters of mercury. The vision was 6/60. Though the chamber was well formed, he has a fibrinous membrane in the anterior chamber. However, the fundus was normal. So we intensified the topical steroids and started him on cycloplegics. However, on the following week, the vision came down to hand movements, and his intraocular pressure was 6 millimeters of mercury. The chamber was formed, but there were a lot of corneal folds, and we can see an over-filtering RD bleb over here. This was the B scan showing large choroidal detachment. We tried managing conservatively in the initial few days. However, he did not respond. The hypotony persisted, the vision was bad, and he had persistent choroidal detachment, and there was no response to conservative management. So what next? So just to summarize, we have a patient with neovascular glaucoma following ocular ischemic syndrome with 5/60 vision, where the intraocular pressure was very high, underwent a diode CPC, following which, though the pressure came down again, it started racing, and we decided to do RD, and we did RD. And when the tube opened, he landed up in bad hypotony, which was not responding to conservative management, and the vision was hand movements. So what next? So whether we need to do a tube religation or tube religation with the CD drainage or ab interno stenting. Here, this is a video showing a tube religation. However, this is not of this patient. This is what we were doing in the initial days when we did not have access to Supramid or a Supralon. We can see here a corneal traction suture is being applied. And we can see here the patch graft is here. And behind the patch graft, I'm able to expose the tube and introducing a cyclospatula to we can see the tube, and now I'm introducing a sixovical suture and religating it in the routine way we do when we implant the RD for the first time. So it is good to limit our patch graft to cover the anterior part of the tube, so that in such situations it really helps to no manage the hypotony by religation, which is like very much possible by exposing the posterior aspect of the tube. And once this is done, the conjunctival closure is done, we can see a kink on the tube as I apply ligation suture. And then once the conjunctival closure is done, so we can see the anterior chamber, a thick membrane is there which is being washed, and following which the anterior chamber formation is done. So of late, we have now the access to Supralon from Aurolab, thanks to Aurolab, which is like a Supramed-like material, 30 nylon, which is a non-absorbable black multifilament. And so we decided with the availability of Supralon to do ab interno stenting. So here is the video showing. I'm making a side port exactly opposite to that of the tube entry, and one more side port to help it to introduce the suture stent into that. And this is a Supralon material. I have just made it to 6 to 7 mm, and then like I'm introducing it into the tube with the help of a forceps. Now I'm using a micro forceps, MBR forceps, to push it further inside the tube, and we need to make sure to push it inside the tube as much as possible. It should not be protruding into the anterior chamber. So following the insertion of the stent, the anterior chamber viscoelastics are removed and the chamber is formed. So 3 weeks later, after the Supralon stenting, we can see here the yellow arrow indicating the Supralon material inside the tube, the size of the bleb reduced. So we can see here the Supralon near the foot plate, and the CD started resolution. Resolution was observed. Here we can see a pre-op B scan and post ab interno post surgical intervention B scan. There is complete resolution of the CDs, and this is the technique. We published it in French Journal of Ophthalmology. And having undergone so many issues where the patients are prone to hypertony, we have now made it as a habit to use ripcord in all patients where we do RD surgery, as shown here. So the ripcord is inserted inside the tube before we even implant, and we make sure to place 2 ligation sutures, one over the Supralon and one directly over the tube. And at the completion of the surgery, we just insert the Supralon in the subconjunctival space and then close the conjunctiva. So this is how it appears in the post-operative period in the subconjunctival space, which if needed can be removed by a small nick on the conjunctiva, as shown here, which has been closed with the vicryl suture. This is a patient with the RD with the Supralon ripcord suture in situ, and we can see here the edges of the foot plate are so prominent, and this patient had a raised pressure at 6 to 8 weeks. After 6 to 8 weeks, when we remove, we can see the edge of the foot plate getting obscured because of a good diffuse bleb. So looking at the literature, I could come across this study which assessed the chances of hypertony in a 4-year period. In 1,292 eyes, the chances of hypertony was around 1.6%. We can see here a significant numbers with Barwell rather than AGV, and the difference was statistically significant. When I was searching for the technique, I could come across this interesting technique where the author has used proline material, which is like initially he has inserted 6-proline in an ab interno approach, same like the us, and then he has tied a 9-proline over it using a side port slip knots, and then he removes the 6-proline, and then he introduces the 7-proline again into the suture. Again, the slip knots are applied through the side port, and again that is removed. So whenever the pressure is getting raised in the post-operative period, these slip knots can be relaxed using NDR laser. So here are some pearls to avoid hypertony in a patient whenever we do RD surgery. The tube should snugly fit into the scleral tunnel, and consider entering the suturing the entry point. This will help us to tackle to avoid immediate post-operative hypertony. Always good to have 2 ligation sutures, especially when using the ripcord, one over the ripcord and one directly over the tube. And venting slits, whenever we are placing, better to place it closer to the ligation rather to the entry point. This is because later when we want to religate the tube, that can be applied like anterior to the top of the previous venting slits. And patch graft, if used, it is better to limit it to cover the anterior part of the tube, and always good to have ripcord sutures in most of the patients. So here are some questions which came to my mind to the panelists. Whenever in we prefer a surgery in eye with compromised vision in angle closure stage of neovascular glaucoma, should we prefer a diode laser or a GDD? If a GDD, with whether it is AGV or RD, considering the cost, advantages and limitations and other factors in eye with compromised vision, and also does GDD post diode CPC makes the eye prone for hypertony? Thank you. And now it is open for discussion. I'm just stop sharing.
Dr. Kavita, could you show the questions once again?
Sure,
The second
sir.
last slide.
Yes, sir.
The one small excellent presentation. I think we have learned so much from this one. Can you hear me, Kavita?
Yes, sir. Yes, sir. So is the
Thank you very
slide
much
visible,
for
sir,
this
now?
wonderful presentation, but just one question, that why was not a trap done when the NBI was not there?
Actually, when the vision was 5/60, the patient had shallow chambers, like not very shallow chambers, but a fully angle closure stage with a very high pressures. So I always feel when the pressures are too high, definitely like doing a trap at some point of the time when the chamber is shallow, the chances of post-operative complications are more. When we do a GDD, at no point of time, like the chamber is flat. So I usually prefer to do GDD in patients with such intractable high pressure neovascular glaucomas rather than doing a trap.
So your shallow AC, according to you, is not a contraindication for putting a tube inside?
Sir, definitely if it is like
You are very
going to
good,
touch the cornea, but here being a pseudophakic patient, in most of the patients we have the advantage of inserting the tube into the sulcus. But this patient we could safely insert in the chamber, and we can see the tube nicely resting on the iris rather than touching the cornea.
Yeah, so Kavita, if this seminar is for general ophthalmologists also, well,
Yes,
it
sir.
is so much easier for them to do a trap, especially when the NVI is not there. And
Yes,
so
sir.
this is just a thought process, because I know you are so good and you have done so many in Arvind, you will be able to do it so easily. This is just a thought. Okay. Yeah, please go ahead. Shweta, please go ahead.
Yes, sir. Like definitely, as far as like the debate is always on, I think
Yes,
we
yes.
have Dr. Sushma who will be talking for trabeculectomy in this patients. Probably like after that also we can come to a conclusion. But I feel whatever is best in your hands, which will work for the patient, should be our first choice to do it in
Yes,
a safe way.
that is the best. That is the best statement.
Yes,
Perfect.
sir.
Shweta, please,
So
moderator.
yeah, thank you for the interesting presentation, Dr. Kavita. A stitch in time did save this time. So we now go on to the next presentation, and Dr. Shweta will be the moderator for that. You're muted, I think, Shweta. Unmute yourself, Shweta.
Shweta, you are mute.
That's right. Yeah, now. So with that, thank you so much, Kavita ma'am. And before we proceed for the next presenters, let me have the opportunity to introduce our moderators who are there with us for today. So just a second, I would be sharing the screen. So our moderators for today is Dr. Santosh Honawasa, who is Honorary General Secretary, AIOS, Director, Medical Services, Center for Sight, Hyderabad, and he needs no introduction, but yes, it's our honor to have Santosh sir in our panel today as a moderator. Next is Dr. Manoj Mathur sir, who is Honorary Treasurer, AIOS, Senior Consultant, Glaucoma Swaroop Eye Center, Medivision, Hyderabad. Manoj sir, he is a very helpful person, and he is, I can say, a very pro-academic person. So definitely thank you, Manoj sir, for sparing time to be a part of this webinar. Next is Dr. Mona ma'am, who is a senior consultant glaucoma services at Shankar Netralaya, Chennai. And of course, it's me, Dr. Shweta. So with that, we move to the next speaker for us today would be Dr. Shefali ma'am. Dr. Shefali ma'am needs no introduction. She is integral part of 3G Eye Foundation from Bombay, and she's a very dear senior of mine. So over to you, Shefali ma'am, for your presentation.
Yeah, thank you, Shweta and AIOS for giving me this opportunity. I'm sharing my screen. Visible?
Yes, ma'am.
Yeah. So good evening once again, everyone. I'm going to talk on 1 second. Yeah. So is it visible?
Yes, ma'am.
Yeah. So this is case of a 58 years old female who was referred to us for a second opinion with diagnosis of left eye proliferative diabetic retinopathy with neovascular glaucoma. And she typically had complained of dimness of vision and pain around the eye for last 3 weeks. She was non-diabetic, which was fluctuating, and she was on hypertensive on treatment. And for pressures, she was on left eye, she was on brinzolamide brimonidine combination and timolol eye drops, beta blocker twice a day in left eye. So on examination, 1 second, I am not able to see, 1 sec. Yeah. So left eye, if you see, her vision was counting finger 1 meter. Her pressures were high, 36 millimeters of mercury. She had microcystic corneal edema, and she had NVA, and there was circumcorneal congestion also and flare. She was pseudophakic in both the eyes. And on right eye, if you see the fundus examination, right eye had PRP scars and the left eye had few hemorrhages with the arteriolar attenuation in the mid-peripheral retina. So this is the slit lamp photograph for the left eye. You can see the florid NVI both around the pupillary border and on the iris. And this is the photograph of the angle showing the NVA. This is the fundus photograph of the left eye, which shows there are few mid-peripheral hemorrhages with widening of the veins, and there is typical arteriolar attenuation. Now, when a patient had photographs around 6 to 8 months back, she had history of, in the right eye, she had history of severe PDR, where the patient had vitreous hemorrhage, and for which later on patient had undergone 3 sittings of PRP also. However, at that time, around 6 to 8 months back, these photographs, you can, the left eye had only mild NPDR. So in this, now the question is, what is the diagnosis of the patient? What is the cause and how do we manage this patient? Now, seeing the clinical features in the left eye, with seeing the NVI, NVA, and high IOP, the diagnosis is very clear that it is neovascular glaucoma. But it is very important that we have to know the cause of neovascular glaucoma. So if we, let's walk through what are the most common differential diagnosis, and how do we come to the conclusion that what is our diagnosis in our case. So we know that the most common cause of neovascular glaucoma is CRVO and proliferative diabetic retinopathy. Less common is carotid artery occlusive disease, which is seen in 13% of the patients. Other rare causes are hyperviscosity states like polycythemia vera, sickle cell disease, and still less common is central retinal arterial occlusion. So in this case, since the patient had PDR in the right eye, patient had undergone PRP, patient was diabetic, which was not under control. So usually the most logical, if you think the most probable diagnosis would be NVG secondary to diabetic retinopathy. But was it? So let's look at how we have to work in the differential diagnosis, how we have to rule out each and every cause. So if you see this patient, now the top photograph is not of this patient's, but I just want to say that what type of retinopathy, the PDR related NVG, when you see the patient, what type of retinopathy you see in those patients. Now in this patient had PDR in the right eye along with vitreous hemorrhage in the right eye, but patient did not develop neovascular glaucoma. On the other hand, left eye had only mild NPDR and which progressed within 6 months to go on to develop NVA and neovascular glaucoma. And moreover, if you see the PDR, In proliferative diabetic retinopathy, vascular changes are more pronounced in the macular region inside the vascular arcade. However, in this patient, the lower photograph of this patient, the changes were mainly in the mid-peripheral retina. If you see the CRVO-related neovascular glaucoma, mainly there are diffuse fundus changes, and the main characteristic feature of the CRVO, if you see the NVG and if you see the CRVO, it is basically the tortuosity of the veins. And in this patient, you can see the lower picture, there is no tortuosity of veins. And in case of the next DD is the carotid artery occlusion-related neovascular glaucoma. Here, typically the venous tortuosity is absent in this type of patients. There are mid-peripheral hemorrhages. There is typical narrowing of the retinal arterioles with widening of the retinal veins. And the more characteristic feature is there that the anterior segment findings, that is NVI and NVA, are more pronounced in this type of patients rather than the posterior segment changes like NVD and NVE, which are seen in PDR and CRVO. But the main thing, the main clinical feature, which was very striking, was the stark difference in retinopathy between the two eyes, which led us to think that it has to be something else, and our probable diagnosis was carotid artery stenosis. And we started working on that. We advised patient for the carotid Doppler or CT angiography to look for the degree of stenosis and the presence of plaque in the carotid artery. We also advised some blood investigations like sugar, lipid profile, and serum homocysteine. And the CT angiography did confirm our findings that there was more than 85% of the stenosis in the left internal carotid artery, and there was a dense calcified plaque, which was seen. So ultimately, we confirmed our diagnosis that this was NVG, which was secondary to the carotid artery occlusion, or we also call ocular ischemic syndrome. Now, how do we manage such patient? So the management in such type of patients, along with the management of neovascular glaucoma, which includes the management of ischemia or hypoxia and also the management of IOP, if we don't manage the cause, we are just 50% of the work is done. So we have to treat the cause. Whenever we are seeing the NVG patient, along with the ischemia, we have to manage the main cause or the main pathology behind it. And whatever the cause of neovascular glaucoma, NVG needs very intensive and aggressive management plan. Otherwise, a patient may go blind from very good vision to blind within a period of few weeks to month. And it is always a teamwork which includes physician, cardiologist, and vascular surgeon wherever needed. So in this patient, we continued the same treatment. We added oral acetazolamide. We prefer to avoid prostaglandin analog because of inflammation. And since the pressure remained high in this patient, we had surgical options of trab versus tube. But in this patient, we chose AGV. And ischemia, we managed with the anti-VEGF injection first, followed by supplemented with PRP. This is a small video of the AGV we did in the supratemporal quadrant. So in this patient, while doing this surgery, one thing in this patient, usually the pressures are high when we are operating NVG. So we have to take care and give preoperative mannitols to avoid the sudden decompression. Moreover, in this patient, if you're operating, especially in NVG, if you have given the anti-VEGF prior at least 1 week before, then the chances of intraoperative bleeding and the antechamber bleeding is minimized. And we prefer to give the anti-VEGF injection at least 1 week prior to the surgery. And even if you have intraoperative bleeding, you can tamponate it with air, or sometimes even you have to close. You have to put insert this viscoelastic and close. Another thing is, if the patient is pseudophakic, such type of patient, which it is always preferable to put the tube behind the iris. So this patient, we followed up with the PRP, 3 sittings were done, and we referred patient for the carotid stenting by vascular surgeon 2 weeks after AGV. And if you see the last follow-up, which was 1 year after, the vision was 660. In the left eye, though the vision, usually the prognosis is very poor, pressures are well under control, and the tube was in place. So coming to the discussion, we know that neovascular glaucoma is a devastating complication caused by the ischemic retinopathy, in which because of the retinal ischemia or hypoxia, there is a release of the angiogenic factors. which leads to the fibrovascular proliferation, which diffuses into the anterior chamber, and ultimately there is NVI leading to the neovascular glaucoma. The goal of the management of neovascular glaucoma has to be, it's very clear. It has to be very early, this early detection, quick intervention, and prevention is the key. For early detection, whenever you see any patient with high risk of retinal ischemia, like poorly uncontrolled diabetes, hypertension, atherosclerosis, active PDR, or there is history of CRVO, always suspect NVG. Always perform gonio and careful slit lamp examination to look for NVI, NVA, and the patients should be called up for, or your follow-up visits has to be more frequent compared to the other glaucoma patients. So intervention, as I said, it needs immediate and urgent attention. We have to treat the ischemia, that is NVI, NVA, as soon as possible. Gold standard is PRP, but these days we are giving anti-VEGF injections, and we are supplementing it with PRP, which reduces the stimulus for angiogenesis and halts the process of neovascular glaucoma. And use of GDD. Now here in such patients, usually in ocular ischemic syndrome, wherever there is ischemia or hypoxia, chances of hypotonia are more. So smaller valves, and especially which are valved, are preferred to avoid the post-operative hypotonia. So in this patient, we chose AGV. And in case of to prevent the painful blind eye, or in refractory cases, cyclodestructive procedure is an option. So prevention, as I said, always address the root cause of neovascularization, like systemic disease, like diabetic hypertension, carotid artery occlusion, and it needs collaboration with the physician, cardiologist, or vascular surgeon. And by doing this, it may help to save a patient's life, or he or she may also be at high risk of developing CVA or myocardial infarct. Ocular ischemic syndrome, the risk factors, we have to know. There's a study which published that the presence of atheromatous plaque in the carotid artery is one of the major cause of ocular ischemic syndrome. And these are the high-risk patients if there is a history of ISD, a history of cerebrovascular accident, peripheral arterial disease, hypertensive, diabetes mellitus, or there is a history of transient ischemic attacks. If you see the grading of carotid artery stenosis by NESET criteria, that is North American Symptomatic Carotid Endarterectomy Trial, if the grade 4 and 5, that means more than 80 to 85%, if there is an occlusion, these patients are at high risk of developing ocular ischemic syndrome, and this patient needs intervention by the vascular surgeon also. And usually it is misdiagnosed as open angle glaucoma. Rubiosis is seen in 60%, 66% of the eyes. And typically in the initial phases of CR, this carotid obstructive, carotid artery obstructive disease, or ocular ischemic syndrome, because of the hypoxia, there may be less perfusion to the ciliary body, leading to less aqueous production, and you may actually see the low intraocular pressure. And typically these patients will have mid-peripheral hemorrhages and the featureless retina. So to summarize, neovascular glaucoma is a very severe form of glaucoma, and it demands urgent management. Patients with NVG must be treated not only for glaucoma, but also for ischemia. Always identify the root cause of ischemia and treat accordingly, and management needs teamwork. Only thing is what I want to stress upon is that neovascular glaucoma is definitely preventable and treatable disease that we must take care. Thank you.
Thank you, ma'am. Indeed, it was a very beautiful presentation, and very nicely you had highlighted the points. We would like Sushmita ma'am. Sushmita ma'am, we are requesting your opinion regarding this particular ocular ischemic syndrome induced neovascular glaucoma. The response to the treatment, is it different as compared to all the other secondary causes of neovascular glaucoma, or do they respond? Do we need an aggressive treatment for this?
So, ocular ischemic syndrome, again, in the acute phase, actually, when they start off with a low pressure, and the causes neovascularization and secondary angle closure. But by the time it reaches that stage, unfortunately, the vision is poorer than in the other neovascular forms. So possibly, I mean, the principles of surgery and everything would remain the same. But as Dr. Harsh said, if there is viable conjunctiva, an initial trabeculectomy is well worth. It is the post-PPV and the other NVGs that we really want a primary tube, if at all. But for virgin conjunctiva, actually, the trabs are quite all right. But it's a difficult thing, and we need to, of course, look at the carotids and look at the ischemic problems more vigorously than them, because just doing surgery and not treating the cause is not going to be, enough.
I think any NVG, whatever the cause, it needs urgent treatment. That is one thing. And second, what we have seen, even if the conjunctiva is virgin in this type of patient, with especially with florid NVI, NVA, so what happens in future, the chances of that, the angle, once angle, there is a zipping of the angle, then the chances that your trap side gets occluded is very high. Actually, we have done few patients with trap, and most of the chances of the failure is much more compared to you do the tube. We have just started doing actually even as a primary surgery when the patient is coming with the NVG, and the results are really good with NVG. Of course, we have patient has to be on the anti-glaucoma medication, but chances of the failure of trap is very high. And the GDD also in this type of patients, especially when there is ischemia, the chances of the post-operative hypotony is always high. So that's why the smaller tubes, the implant size, and the valve one, that is preferable over the non-valve one. So I think the last case what we have seen, so one of the reason for hypotony was also because the THC piso-cyclodestructive procedure was done. And second thing, because already non-valve was used. And in such type of your case, Dr. Kavita was also ocular ischemic syndrome. Those cases, because of hypoxia, these patients are very prone for hypotony. So we are doing AGV in all the patients. In this patient also we chose AGV, but when I was going through the literature, so I found that in this type of patient, actually AGV is much preferred, especially in ocular ischemic syndrome.
Yeah, but with the ripcord in place, I mean, I'm really happy with the lack of hypotony now. The way we used to be so scared by the time it was 6 weeks, the ripcord really does not allow anything to go out even when the vicryl is open. So in that sense, there's a lot of, and it's the fibrous capsule with the AGV, which is why AGV has come out with the ACP now, because they know that worldwide, the surgeons, if you follow them long term enough, the AGV is not so good. So even the ACP is a good this thing. It's a stiffer tube than the ADI, and possibly would be more predictable there. But of course, if someday we get the Paul tube, that would be even better because the lumen is even smaller in that. But having said that, if there was pseudophakic, an ECP is also a viable option, because tubes are not without their complications. And in a non-seeing, very low vision eye, I would be very, very circumspect as to make them. So if you have a resource to an ECP and endocyclophotocoagulation, that is also a good option in low vision eyes. We do that often.
Thank you, ma'am, for your insight in the subject. Now, in the interest of time, we move forward and we are just jotting down all the questions which can be taken in the last when the open house discussion takes place. So with that, I hand over the stage to Dr. Mona, ma'am, for the next speaker.
Thank you, Shweta. I now call upon Dr. Sushma Tejwani to share her presentation with us, and I'll share my screen for the introduction. Is my screen visible?
No, we cannot see the screen.
Can't see the screen.
I think all the participants know Dr. Sushma very well, and you can just text her or introduce her.
Okay, so it's my pleasure to introduce Dr. Sushma. She's a consultant in HOD glaucoma, Narayan Netrale, and I recently had the pleasure of meeting her in San Francisco, and we had a nice time together. And I hope to enjoy the presentation today, and I hope everybody does too.
Thanks, Mona. Thanks for that kind introduction. And
I'll stop sharing.
And I'm really grateful to AIOS and Shweta for giving me this opportunity. I'm just going to start share screen. Yeah. I think it's visible now.
Yes, ma'am.
Okay, so I think we are destined to discuss some common problem with different treatments today. So I'm with the topic that does good old trabeculectomy still work for NVG? So I'm going to share a story of a patient whom I have not treated completely and partly. So the history is a case story where a 68-year-old gentleman who's diabetic, hypertensive, and had some cardiac issues since last year, and it was on treatment for those things, had undergone cataract surgeries 4 years back, and reported not to me, to the referral surgeon, with a sudden drop in the vision in the left eye. Now he was diagnosed to have vitreous hemorrhage in the left eye and was advised vitrectomy. And vitrectomy was done there with my retina colleague, not my retina colleague, the referral doctor again. So at the time of vitrectomy, they noticed that there were few hemorrhages in the mid-periphery in the left eye, and other eye retina was normal. So I think we are seeing a lot of carotid Dopplers today and ischemic workup. So this patient also had advised the carotid Doppler and ischemic workup in view of the nice picture that Dr. Shefali had seen, that kind of a mid-peripheral hemorrhages on the retina. So the patient did have 90% stenosis in both the carotids and underwent stenting of both the carotids for that after the vitrectomy. Now, after 3 months, left eye developed neovascularization of the iris again and high IOP, and he was diagnosed to have neovascular glaucoma. They did PRP to treat the retinal ischemia, and we was started on anti-glaucoma medications to reduce the intraocular pressure. And intraocular pressure was not controlled in topical and oral medications. So that is when I get a call from this referral doctor, and pressure I was told was 38 with all these 5 medications along with the oral acetazolamide. So I told to continue with the acetazolamide and add lotipred and send the patient to me. So when I saw the patient, this is how the findings were. That was in 2022, that is 2 years back. So right eye was quite fine, 6/6 vision with the normal pressures and pseudophakia, normal disc. Left eye had 636 vision, improving to N6, and that time the pressure was 22. There was NVI and sluggishly reacting pupil. There was peripapillary edema at the nerve, and because the recent PRP was done, and I could see the laser marks. This is how the slit lamp examination looked like. So there were multiple NVIs, as you can see there. So this is a slit lamp video of this patient. This is the NVI you can see at this pupillary border, and even on the other side. And when I did the gonioscopy, I could see there's a zipped angle. The nasal angle was zipped. And when I saw the other angle there, you could see the inferior angle did have neovascularization of the angle. Same for the nasal angle, and the inferior angle, you could see there was part of the angle was closed and part had NVA. So that's how it looked like. When we looked at the fundus, this is how it was. So the nerves looked pretty okay, and the right eye fundus was completely normal. Left eye had some laser marks, fresh laser marks, as you can see in the periphery, and the nerve looked more or less okay. Rather, the cup was looking even duller than the right eye. So I'm purposely showing the OCT first for this patient. So OCT looked more or less normal in the right eye, and left eye rather had a higher thickness, maybe due to edema in that area. And when we looked at the macular GCC, even that looked quite okay in both the eyes. Now, this is how the fields of the patients were. So the right eye also had a significant amount of blind spots, and the left eye was worse. When we looked at the 10-2, this is how it was. So now it looked like that it is not only glaucoma. This was the left pie in the floor and sky defect, actually corresponding to the infarct in the right parietal and temporal lobe. That is, I'm telling you right away, but looking at this fields, I ordered the MRI for this patient, and this is how it worked out. So probably that was causing damage to the superior and inferior fibers of the optic radiation, giving rise to this kind of a field defect. That is how we had GCC also normal, because in macular GCC, you would see changes related to the till optic tract. Beyond that, you will not see changes in the GCC as well. So that was related to the quadrantanopia or hemianopia kind of picture. So anyway, this patient was diagnosed to have pseudophakia with neovascular glaucoma in the left eye and ocular ischemic syndrome after vitrectomy and PRP and intravitreal anti-VEGF injection, and also had right superior and inferior incomplete quadrantanopia. So I decided to do a trabeculectomy with mitomycin C under guarded visual prognosis after intravitreal anti-VEGF. So we gave one anti-VEGF, and after 3 to 4 days of that, we did a trabeculectomy. Now, I'm also a believer that trabeculectomy does work in neovascular glaucoma, provided you are given enough amount of anti-VEGF and close to the trabeculectomy so that encounter less bleeding. The retina is well lasered, so you will have reduced the ischemic cause. And mitomycin C is definitely a must in these cases. I prefer to use a releasable suture in these patients because I don't want sudden hypotony, and I have the capability to, be able to reduce the pressure afterwards. But in this particular patient, because he was not in town, is not going to be on follow-up with me, I did not use a releasable suture, assuming that they may not be able to take care of that. And if at all it happens, I may do a suturolysis if the patient requires. So this was a normal trabeculectomy, the MMC, with no special technique. Post-operatively, day 1, the vision was 660, the pressure was 14, the blood was diffuse, and you can see this is the first post-operative picture, the sutures being in place. The AC was well formed. There was no significant inflammation as it looked like, but when you looked at carefully, there was a bit of hypopyon there, hypopyon kind of a picture. I was surprised at how we are having hypopyon. Then there was a blood mixed in that, so probably there were cells, because rest of the picture was not matching with the hypopyon picture. There was no lid edema, no pain, etc. So anyway, we just started with routine post-operative treatment, topical steroids and antibiotic and cyclopentolate, and no anti-glaucoma medications. And this hypopyon actually disappeared in 3-4 days. So it looked like that was a collection of cells along with the red cells. And there was no, thankfully for me, there was no significant inflammation, and IOP remained quite okay without any medication. After that post-operative course, he was back with his referral surgeon, and the IOP stayed well controlled for 15 months and then started rising again. That is when I started getting the call. So he was started on AGM. After 3 months, he developed new vascularization of the iris again and underwent anti-VEGF and additional PRP with the primary doctor. So recently he came back for follow-up. After that, he had been on brinzolamide and timolol drops, and thankfully has been doing pretty well. You can see the vision is 6 parts, the pressures are 11 with these 2 medications. And now there are no NVIs because he underwent PRP and intravitreal anti-VEGF injections even after that. Now, if you look at the nerve, you can see more of pallor on the left side. When I saw him now 2 years later, this nerve remained the same. And you can see those laser marks have also matured now. If you look at the fields, this quadrantenopia, heminopia still remains. And now you can start seeing changes on the OCT on the left side. If you see, right eye was normal, of course. So now we can see as the thinning was established, you could see the NFL thinning and the changes on the GCC itself, which were related to glaucoma. So I just continued this patient right now on the medication and kept on close. I'm advised to be on close follow-up for his glaucoma, retina status, as well as the systemic situation. So I do agree that trabeculectomy does work in neovascular glaucoma, or any glaucoma surgery for that matter works in NVG, provided there is constant monitoring for ischemia, and we are watching for the new vessels, and timely intervention is done at each step to maintain the vision in these patients. So you have to look at all these, look at the IOP, NVI, NVA, and disc every time, look at the retinal new vessels, look at any systemic issues, and keep managing them with whether it is anti-glaucoma medication, surgery, trab, or shunt, whatever works best for you. For taking care of the ischemia, you have to give anti-VEGFs or do laser and vitrectomy if required, and also take care of the systemic conditions. In addition to that, it is important to control the inflammation in these patients so that you don't lose your surgeries because of inflamed eye. That definitely leads to good outcome in many of the situations. Well, thanks to Shweta, when I looked at this case, I thought, let me do some literature search and also look at my own patients. So when I looked at the reported outcomes, our own group from LVP, Dr. Sirisha et al. Have reported success probability of trabeculectomy in different types of NVG, ranging from 50% to 75% in PDR, ocular ischemic syndrome, and vein occlusions. And the risk factors for poor outcomes are reported as PDR and persistent new vessels, higher number of anti-VEGF injections, or delay in performing trabeculectomy. There are reports which compare trabeculectomy versus tube, and some reports say that trabeculectomy works better. Some other reports say that shunts work better. So that is, as we already discussed, is an individual choice and individual patient. It depends on. Sharing my experience, I just pulled out my cases, what I have run TRAB for in last 5 years for NVG cases. So the 17 TRABs that I did, there I found pressures less than 20, 14 cases. Absolutely high pressures in 3 cases, despite of everything. Out of these 14 cases, 6 cases were without medication. So only 35%, but the qualified success, that means with 1 medications or more than 2 medications, we had almost 47% patients or 8 patients. The failures that I had, we did the ARC for 2 of the patients, and 1 patient had a vitreous hemorrhage. So vitrectomy and anti-glaucoma medication is what is going on for him. So having said that, I just want to convey that we need to remember that it is crucial to look at the cause of neovascular glaucoma at the time of diagnosis. The primary cause, ischemia, inflammation, and systemic issues have to be addressed simultaneously. Nothing one by one, all have to be addressed simultaneously. Trabeculectomy as well as glaucoma shunts are effective. Aggressive and faster approach is definitely required to have better outcomes in these patients. The patients who have undergone a previous vitrectomy have very proliferative diabetic retinopathy, present at younger age, or who have fellow eye also as NVG. These are the poor prognostic factors. And delay in treatment, of course, leads to poor outcomes. Thank you for your kind attention.
Thank you for the wonderful presentation, Dr. Sushma. So old is always gold, but you found ways to make it shine better. And also you highlighted what happens when after carotid endarterectomy, the reperfusion occurs and the pressures spike again. That was one thing which your case beautifully highlighted also. So I would now request Dr. Chandrama Paul ma'am to comment on the case and also tell us about her modifications for a TRAB in eyes with NVG.
Thank you, Dr. Mona. Good evening, everybody, and apologies for late joining. Thank you, Shweta and AIOS, for having me here this evening. It's indeed a pleasure to be here with all of you. Going straight to your case, Shushma, is as usual, very well presented. And let me tell you, I'm also one of the believers that if there is a good amount of conjunctiva, and of course, reasonably good vision in that eye, then it's definitely better to go for a TRAB first, if it works well in your hands. And if the vision has dropped already, then of course, definitely endophotocoagulation is a better option. And I think everything that you did, I would have done the same things. And here, maybe I would like to stress that, 10 years back when we did NVG TRABs with, say, with bevacizumab injections, and now when we do them with ranibizumab injections, I think it's much better because the level of anti-VEGF injections which we give have improved, and that actually helps. And what Dr. Mona also just highlighted is that when second time there was iris neovascularization and you again gave anti-VEGF and PRP, I think that worked wonders. And anti-VEGFs nowadays are better. And well, for us glaucoma people, after ranibizumab, we haven't had much of a choice because we could not give brolucizumab and things like that. But we are again waiting to see if there's another anti-VEGF in the pipeline or maybe some biosimilar, which we could use, like we moved from Avastin, from bevacizumab to ranibizumab, and maybe a next one, which would also help us. And TRAB is actually a wonderful surgery in hands which work well in TRAB. And for those where shunts or valves work better, it's actually your individual choice. But given my choice, I would definitely go for a TRAB first, provided there is good amount of conjunctiva and the patient has some amount of vision. So I would do exactly what you did and wait on and see what happens. That's it.
I think, as you rightly said, any surgery would work for that matter as long as you're taking care of the other factors and looking at individual patients' requirements, a condition of the anterior chamber and other factors. So as long as we do a comprehensive management in neovascular glaucoma patients, that is what works best.
Yeah, one thing is that there was a reasonable amount of inflammation after your trap because of that hypopion which happened. So there was a reasonable amount of inflammation, but then in spite of that, the trap did work well since the pressures and everything are still controlled and good on follow-up.
Thank you.
So one more thing which I would like to ask the panel is that we would always like our GDD or TRAP to work forever, but unfortunately, as we saw Dr. Sushma's data, also it doesn't happen like that. It can fail over a period of time. So what would be your second procedure of choice? If your TRAP fails or if your GDD fails, primary GDD fails, what would be the second procedure of choice?
So that's precisely why I do the trap first, because I keep GDD as a backup so that I have some more time. And I'm pretty sure that trap is not going to work lifelong, particularly in NVG patients. So that's a backup plan.
You would not do a retrap.
Well, if the conjunctiva is there, I may even do a retrap, then second tube, and then the first tube, and then the second tube, if you ask me the sequence of events. If the bleb is big enough and the mitomycin and doesn't allow me the superior conjunctiva, second trap, then I would go for the GDD. But yes, I still do second trap even for NVG patients if the first trap fails.
According to my whatever I have done in my cases, just would like to share the experience that if the angle is open and the patient has come to you at an open angle stage, in majority of the cases, the trap, it really works. It works. Then probably we can just go for the second options.
Yeah, based on how long you would have the success of the first trap, if it has worked significantly well, then well and good. But if it has failed in second, third month, there is no point doing a second trap. Then you directly go to a tube.
And also how active the neovascularization process was during the first trap. I feel it may become more quiet during your next trap.
Yeah, true.
And the other thing is, the other eye was good. So that's also an added bonus. If the other eye was also bad, then maybe you'd first think of a GDD.
Yes.
So I think I now ask Dr. Shweta to moderate the next case.
So with that, we move further ahead in the discussion today. So now we are having our next presenter with us, Dr. Shahinur Tayyab. It's my immense pleasure again to invite Dr. Shahinur as a presenter tonight. She is always there whenever you are asking for any kind of academic involvement. A big yes comes from her side and a big thank you for that to Shahinur. So Dr. Shahinur is a senior consultant at glaucoma services at Sri Shankar Dev Nethralaya, Guwahati. Over to you, Shahinur.
Thank you, Shweta. I'll share my screen now. A very good evening to all, and I'm really thankful to Shweta for giving me this opportunity. I think my screen is not coming full screen, is it?
Yeah.
Now is it coming full screen?
Yeah.
Okay. So a very good evening to all. I have given a title, Hope Springs Eternal, but the battle is far from won. Of late, we have been getting a lot of neovascular glaucoma cases, and no case or no treatment is final for these patients because new problems spring up and you have to be prepared. What should be your next strategy for this? So for this, So the patient first presented to us in October 2020, a 60-year-old gentleman. He first presented in the retina clinic, actually. The initial few visits were in the VR department. So he had presented with bilateral proliferative diabetic retinopathy with macular edema of 1 year duration. And he gave a past history of having undergone intravitreal anti-VEGF injection 1 year back elsewhere, and a PRP was also done. He was diabetic for the last 10 years. And when he was examined, he was already under anti-glaucoma medications, latanoprost and dorzolamide.
The best corrected visual acuity in the right eye was PL negative, and in the left eye, it was CF 1 meter. So on examination, the intraocular pressures were normal, 15 and 16 with medication. And the right eye had corneal edema with bulle, and the left eye anterior segment findings were unremarkable. And on fundoscopy, he had vitreous hemorrhage and NVD. A diagnosis of blind eye was made in the right eye and PDR in the left eye with vitreous hemorrhage. Ultrasound was also done, which revealed low reflective intragel echoes. This is for the left eye, and ONH cupping was also noted with increased macular thickness. So he was advised fill in PRP in the left eye, which the patient underwent. And then after that, he came for a review. Normally, the patients are called after a month, but this patient came after 4 months. And by the time, the left eye vision had improved to 618, and the IOP was 16. He was still on anti-glaucoma medications, and an OCT macula was done, which showed cystoid macular edema with epiretinal membrane. The patient he had significant cataract, and he was advised cataract surgery, followed by VR intervention for the retinal problem. However, the patient refused, and this time he came back after another 9 months. That is in December 2021 he came. So this time he came prepared for the cataract surgery, which was done. And at the final checkup, his vision had improved to 612 in the left eye, and IOP was 14. And the fundoscopy showed a lasered retina, and which was stable. 3 months after the cataract surgery, the patient suddenly came with a shadow falling in front of the left eye, and his vision had dropped to counting fingers 2 meters. And the IOP was noted as 19 in the left eye, and on slit lamp examination, NVI was noted, but the angles were all open up to scleral spur. And fundus showed lasered retina with macular edema. He was advised intravitreal anti-VEGF injections. But after this, again, the patient was lost to follow-up. And this time when he came back, it was again after 7 months. In September 2022, his vision was CF 2 meters still in the left eye, but the IOP had increased to 36. And then this time the patient was sent to the glaucoma clinic. So in the glaucoma clinic, we had advised him timolol and brimonidine fixed combination. Dorzolamide was also given along with oral acetazolamide. So with this medication, his IOP came down to 11 in the left eye. Slit lamp had NVI still. And on gonioscopy, now that the cornea had cleared slightly, we could see that NVA was there, and the angles were closed in superior and inferior quadrant, and on the nasal and temporal, it was still open. So this patient was again sent back to the VR clinic for further management, and they decided to for intravitreal anti-VEGF injection. After 3 weeks of the NVI, the intravitreal injection, NVI had resolved, the cornea had cleared, but the IOP was still 34. So the patient was on 3 medications, and we added prostaglandin this time, and the patient was closely followed up in the next few weeks. And subsequently, we had counseled him also for tube surgery, but he was not willing. So again, netarsudil was added. And the patient came back after a month, this time with complaints of watering. He had developed corneal toxicity due to the number of anti-glaucoma medications. Vision was counting fingers 1 meter, and on slit lamp examination, we could see the roughened and irregular cornea with an epithelial defect. IOP with tonopen measured 27 millimeters of mercury. So all anti-glaucoma medications had to be stopped. We put him on topical lubricants and oral acetazolamide. So in another 3 weeks, the cornea had healed completely, and the IOP was 25. He was on oral acetazolamide. We did a specular microscopy, which showed decreased cell count, endothelial cell counts, and the patient was advised for Ahmed glaucoma valve implantation in the left eye. So 1 week after the AGV, we injected subconjunctivally mitomycin over the plate, which was also given after 4 weeks. So at 6 weeks, at the final checkup, because the IOP had come down to 6 and 8 in the follow-up visits, so I stopped the oral acetazolamide, which he was on. Vision at the final checkup of 6 weeks, he was 6 counting fingers at 3 meters. IOP was 8, not on any anti-glaucoma medications. AGV tube was implanted in the sulcus, and there was ectropion UVA. There was no NVI, and the disc now could be examined, and it was noted to be pale with a cup disc ratio of around 4:1. And there was vitreous hemorrhage. The patient was again referred to the VR clinic where fill-in PRP was done. This is a fundus picture that was taken at 6 weeks after the valve surgery. So after the PRP, 1 week later, he now comes with a sudden decrease of vision in the left eye, and examined in the VR clinic, they found there was vitreous hemorrhage. So again, an anti-VEGF injection was advised, and he was again sent to the glaucoma clinic for a clearance before the injection. So unfortunately, that day I was not available in the outdoor. My colleague had a look at the patient, and he noted an exposed suture here at the, initially I was actually suturing the scleral flap this way, and they used to lie subconjunctivally. So somehow this suture had eroded, and there was an exposed end of the 10-0 nylon near the scleral patch graft. And he did a force needle test, which led to a leak at that site. So unfortunately, over the next few days, the leak only increased. We had put the patient on topical antibiotics and oral antibiotic also, but the leak only increased. So, and along the follow-up course, when the leak increased, we decided to put a PRF and a conjunctival graft was applied with glue over the leaking area, because it was directly not bathed in aqueous, so we thought it will be successful, but unfortunately it did not work. And after the PRF, when it was still in situ, we could go ahead and with the intravitreal anti-VEGF injection. But the leak persisted, and after the PRF dislodged, what became obvious was that the plate itself had now dislodged and it migrated downwards, and the edge of it could be visible at the exposure site. So there was no option but to explant this plate. So at 6 weeks from the start of the leak, and at 6 weeks, we had to put in a fresh AGV in the inferonasal quadrant, and the exposed AGV was explanted. So this is a picture at the end of the surgery. You can see that this is the inferior AGV with the tube again in the sulcus placed, and superiorly the AGV was explanted and the conjunctiva sutured. So again, at 1 week and 4 weeks, a subconjunctival injection mitomycin was given over the plate. And this time the intraocular pressure was not very well controlled. And so we had to put him on timolol maleate. But the patient again came back after a month or so, and he had discontinued the AGM. And at final checkup, which was on 19th of January, his vision in the left eye was found to be CF 3 meters. The IOL and tube were in situ, and IOP was 25 with no AGM. He had discontinued it. The disc was pale, and OCT showed disruption of the IZ, meaning that the vision is not going to improve any further. So again, we had to start the patient on anti-glaucoma medication. I think I had restarted on timolol maleate. So that is the case. Thank you.
Thank you, Shainur, for presenting such a nice case. Now we would request MDA sir to share his experience regarding the management, and whenever we are planning to do a GDD in such kind of eyes. Sir, are there any extra tips which you would like to share with the audience?
First of all, I would congratulate that the best surgeons of the country you have collected from the best of the centers, and all these cases have been the most difficult cases have been, managed so well. Each one of them was an exemplary case to learn so much from each case, and all of us must be learning, I'm sure. Uh, Besides that, there's only one point which I would like to raise, and that is the ischemic process continues. It is not a one time that we have done stenting of the carotid once and no further plaque can appear. So we need to keep a watch on them, especially the cases which showed recurrence. There should be a repeat carotid angiography or carotid Doppler done, and we should look for a new plaque over there. So I think that is the only thing which I need to add in the whole of the discussion and the cases that have already been presented so well.
Thank you very much, sir. Sushmita ma'am, what is your take about the tube shunt exposure in some kind of eyes if they are having this neovascular glaucoma, like the diabetic eyes with PDR? Are they more prone for the tube shunt exposures?
So, tube shunts can expose, frankly, tube shunts can expose in any. I'm not sure whether diabetics are more at risk. I think the problems of the tube shunt is more to do with the irregular surface underneath the conjunctiva and an irregular ocular surface. And George has in fact shown that when he has shifted to a patchless graft, his tube shunts are much less. What we do is we really make the scleral patch graft really, really thin because the irregularity is a problem. That's one. The second would be not suturing conjunctiva under tension at all. We do relaxing incisions in the fornix and see to it that if the conjunctiva is sutured under tension, the myofibroblast of the tenons is going to make it erode. In children and young patients, rubbing and frequent doing that is another problem, which is why children are a different ball game altogether. But I'm not so sure whether diabetics, I don't recall diabetics being more at risk, but we do give them doxycycline for very small erosions. And many times the immunomodulatory effect of doxycycline helps healing, and you don't need to go in and do multiple resuturings.
Thank you, ma'am. Actually, when I was just going to the literature for this webinar, I just came across an article which said that in diabetics, due to low perfusion and low remodeling of the conjunctiva, the tube shunt exposures are more. So I just wanted to clarify that doubt. Thank you very much. So over to you, Mona ma'am.
I would also like to ask regarding the role of mitomycin with AGV. It's a little, some prefer it, some don't. So I'd like to know the take.
Risk, yeah.
I think most of us in India are not using it, but I've just recently, during the UK PGS, happened to go to the Moorfields as well. They use MMC really, really aggressively. And according to Dr. Keith Barton as well as Penko, apparently the tubes do well because of that. And interestingly, they use spears and they just shove it into the pocket over the plate. And then with the tuberculin syringe, they slowly inject the MMC into the spear, which is already behind. So I thought that was a very innovative way of doing that. And I've come back and I've done it in 2 patients. So let's see, I mean, hopefully. But apparently the capsule will otherwise be very aggressive in the sick eyes. And that's what they said. So let's see. So far, so good. But I must confess that we really don't usually do and use MMC with tubes.
And some of the cases where we removed the cyst, once the cyst was already formed over the plate, in 2 or 3 of them, we have done exactly the same thing, though I didn't know that these guys have done it like this. But we had put in the spears and done this thing, and those guys have done really well. So I think it should, I think you are right, we should try it in our routine cases as well.
And the other thing, sir, is when we didn't use it. I have stopped doing AGV long time ago, but these fibrous capsules really get inside the valve and inside the tube, and you have to really, really pull them out. So it's really very aggressive when it happens. So maybe it has a role to play, and we
Let's
must,
start that now.
yeah, that's one takeaway.
So we look forward to your results, ma'am. Next, I call upon Dr. Sudipta Ghosh. She's HOD and consultant, Rabindranath Tagore International Institute in Kolkata. And we're looking forward to her case presentation.
Okay. Good evening, everybody. It is indeed a pleasure to be amongst all of you. Today's case presentation. A 73-year-old gentleman of
Sudipta, your voice is not clear and it's not loud enough. You can come closer to the mic or something.
Okay, now is it better?
Slightly better, but we would prefer even better if possible.
Uh,
Any chance you can bring mic to closer to you, Dr. Sudipta?
Can you hear me now?
Better, better.
Okay. So today it's presenting to you a 70-year-old gentleman of African-American origin presented to our OPD with a painful blind right eye. He was a known case of diabetes with hypertension and left ventricular failure and chronic renal failure stage 5. He was registered under the International Program of Renal Transplant with uncontrolled diabetes and hypertension and undergoing dialysis 3 per week. He was on maximum anti-glaucoma therapy. Now coming to the ophthalmic examination of the right eye, visual acuity was hand movements close to face. There was lid edema, conjunctival congestion, mild corneal haze, pupils were sluggish in reaction, with 360-degree neovascularization of the iris and angle structures on gonioscopy. He had dense cataract of grade 4 and his intraocular pressure was around 56 millimeter of mercury. Due to the cataract, he had poor retinal glow with severe proliferative diabetic retinopathy and pan-retinal photocoagulation was done previously elsewhere. On examination of slit lamp, we saw 360-degree neovascularization of the iris, and on examination of the iris, we saw there was inferior angle reveals iridus and there was superior angle was involved too. So what next? So the primary outcome of this patient was to control the intraocular pressure, to relieve the ocular pain, to assess the visual acuity at 6 months, and to see or assess the regression of the anterior segment neovascularization. So the treatment modality that was performed, ocular light electric semiconductor diode of 810 nanometer laser was done using the contact G probe of 0.7 millimeter. This was a 600 micrometer quartz fiber. 30 to 40 laser shots were given, around 22,000 microwatt for 2,000 milliseconds. Along with that, intravitreal commercial desoximab was given, 0.05 ml, 3.5 to 4 millimeter in the superior quadrant, and aqueous humors was released so that the intraocular pressure was kept under control. Now coming to the follow-up, the intraocular pressure at presentation, as I said, was 56, and pre-treatment after the anti-glaucoma medication, it was 42. At 1 month, it came down to 28 millimeter of mercury. For 3 months, it was 22 millimeter of mercury, and at 6 months, 60 millimeter of mercury. As you can see from the chart, ocular pain was relieved from severe to almost nil, and visual acuity, though there was not a gross improvement in the vision, but at least from hand movement to counting finger 1 meter was achieved at the end of 6 months, probably because the corneal haze in this patient was cleared up a bit. Although the cataract was not disturbed and further intravitreal, any other procedure was not performed. If regression of the anterior segment neovascularization in 1 month was observed, as you can see, there is a complete disappearance of the NVE as well as the neovascularization at the angle. So concluding the case, several outcomes, including reduction of the intraocular pressure, resolution of pain, and resorption of anterior segment neovascularization was seen with a combined treatment, which is not technically demanding. All the previous cases we spoke about, we saw trabeculectomy was done, acute surgery was done, intravitreal injections were given, but in patients where visual recovery, we see that is not good, or whether they will not achieve a good visual recovery, a probably transparent dye cyclophotocoagulation can be done to reduce the pressure in such eyes. The short-term results suggest that intravitreal bezuclastinib is well tolerated and treatment induces rapid regression of the neovascularization. Although further studies are required to see whether the combined therapy of the diet and the intravitreal pressure can work or not, a study should be done in these such cases. So why was this case chosen? Since I'm working in a multi-specialty hospital where our OPD solely consists of patients with multiple comorbidities, knowing about the mechanism and influencing and risk factors of refractory glaucoma, it is important for our day-to-day practice to know, to diagnose, to assess, and to treat such patients accordingly, so that whatever visual recovery can be found in such patients should be given back to them. Because we never know, if one eye has gone in for such a refractory glaucoma, and probably in some time further, the other eye may also get affected. Thank you so much for your kind hearing. Thank you.
Thank you, Dr. Sudipta. You nicely highlighted that NVG is just the tip of the iceberg, and there are systemic issues which the patients can have. So I would like to ask the panel here, especially Dr. Chandrama ma'am, what would be the settings for diode cyclophotocoagulation? Would you use the usual settings, or would you change them in some way for NVGIs?
Yep. So, very nice presentation, Sudipta. I'm curious, I want to ask Sudipta that why didn't you do the cataract? It was a nuclear cataract grade 4, you said. So after giving the intravitreal, I would have done the cataract along with the...
Actually, the permission was not given by the nephro department because his hemoglobin was also very low. It was around 6.5, the hemoglobin of the patient. And since he was on dialysis, they didn't allow me to go for any intervention for the cataract.
All right, but that's a little strange because we do the cataract on the topical. So like there should not have been any kind of a contraindication as such, because removing the cataract would help with a good view of the fundus later on if anything else is required. That is it.
But then I could not reason out with them for this case. Usually, actually in our nephro department, I'm not sure why, but any intraocular intervention, even if it's simple cataract surgery under topical, somehow we don't get the permission to operate. So they wait and watch, and then they observe, and then after time, so that's what happened. And his diabetes was also not under control, even though I had suggested for a infusion of insulin and to do it under infusion, but still permission was not given. Because the patient was already registered under the renal transplant, and his renal transplant was due after 10 days time, till after I did the diet and the intravitreal injection. So they wanted to settle that part first, and the patient is there to come back for follow-up after his transplant, because usually they give us a period of 3 months time to 6 months time after transplant, after which we can go for any other intervention. So I'm still waiting for the follow-up to come back. So let's see.
And the endocytophotocoagulation which you did, was it a continuous pulse, or was it the continuous wave or the pulse trans?
It was a pulse.
It was a pulse.
Yes. So we use actually we don't have the machine ourselves. We got a demo from the company. So this was 2 or 3 cases we did. And they have given us the fiber optic fiber also, just to find out where the ciliary processes are. So this was around, say, 1.5 millimeter from the limbus. So we had the ciliary processor, and the diet was done. So luckily the patient did well. He recovered. But actually what you said, the cataract should have come out, but then since the permission was not given to us, so we are still waiting for him to come back after his transplant. So let's see. His transplant is done and he's doing well in that case. So he's on a follow for the transplant thing. So he will be back probably in a month's time to us.
All right. And did you do the cytophotocoagulation along the hemispheres?
Along the hemisphere.
3 through 9?
Yeah.
3 to 9
3
on
to
both
9.
the
No,
hemispheres?
we left the 3 and 9 position. Usually in transcleral, the third 3 o'clock position and 9 o'clock position is left because the ciliary nerves while there.
Yes, and you do
So
the rest of the
do
places.
the rest of the call.
Yeah. And
So
how many?
I was frankly speaking, I was not very aggressive in doing the cytophotocoagulation, thinking that what if it goes for hypotony or you lose the eye, because the patient was more keen to get his transplant done rather than to fix his eye. So I was a bit on the not too aggressive on the diode. So the intravitreal injection did work well, and since he was an international patient, so I had to be very skeptical about what I do to him and what was explained to him.
And the IOP is controlled now?
IOP is controlled now. He's on anti-glaucoma medication for that case, but his IOP is under control.
Okay.
Thank you so much. Right. Thank you, Dr. Shweta, for having me on the show today. Thank you.
So I now call upon Dr. Shweta to introduce the next speaker and moderate the next case.
So Mona, thank you for moderating my session. Thank you so much.
So thank you, Mona.
Pleasure.
And with this, we come to the end of the case presentations. And after that, we are going to have an open house discussion so that the audience can have some 5
Dr.
pointers
Vinita has
regarding.
joined. Shweta,
Ye-
Dr. Vinita has joined.
Yes, sir. Yes, sir. Yes, sir. I've seen that, sir. So I was coming to that only. So the last case presentation for today is by Dr. Vinita Ramnani ma'am, who is a consultant in Department of Ophthalmology at Bansal Hospital, Bhopal. Over to you, Vinita ma'am.
Thank you so much, Dr. Shweta, and sorry I joined late from BOA. I will be presenting my case. So is my slides visible and I'm audible?
Yes, ma'am. Both.
Okay. Thank you. Thank you, AIOS, for giving me this opportunity. And thank you, Dr. Shweta. This is a 68-year male, which was seen by me in December 2020. He's a known case of an diabetes, which is poorly uncontrolled from 20 years, as well as hypertensive and triple vessel disease. And he suffered an MI in 2017 with ejection fraction of 45, and he was advised to go for CABG and he refused. So he presented to me saying that he requires a cataract surgery because of the marked reduction of the vision, which he was suffering in both the eyes, more so in the left eye from past 6 months. And there was a history of macular laser done on the retina in 2004. After that, there was no follow-up till 2020 in March, when he went to some ophthalmologist and she advised a diabetes control and cataract surgery. Following that, a retina management as per the patient statement, though records were not available. So we come down to December 20. It's a long story till 24. So he presented with best corrected visual acuity of 612 and 624 with applanation 24 and 18 millimeters of mercury with open angle on gonioscopy. There were no neovascularization at angle, though there were few neovascularization front present at the pupillary margin, though I don't have a record for anterior segment photo of 2020. But this is the fundus photo. One can see he had an extensive proliferative diabetic retinopathy involving the blood vessels at the disc. So the extensive neovascularization at the disc, as well as in the left eye and the right eye, though the left eye was involved more. So I have magnified the image on a disc on a lower side. So one can see a huge neovascularization at the disc. And this is the OCT, which shows definitely the macular edema. So the diagnosis is an advanced proliferative diabetic retinopathy with the pale disc and neovascularization at the disc with cataract and neovascular glaucoma. And he had diabetic nephropathy, cardiac problem, and uncontrolled hypertension and diabetes because his HbA1c on presentation was 14.2, the urea 49.2, and creatinine 2.10. That means he was medically unfit for the things, and we could not do an angiogram. And in a span of 10 days, he progressed. So the choice left was to give an intravitreal injection of ranibizumab. And after the first injection, he recovered well and given a second injection because he was improving so well that thought of getting a good control, but unfortunately he lost to the follow-up because of the COVID, and he came after say about 4 months with progression in his neovascularization, uncontrolled IOP, reduced vision, and so also the retinopathy. So again, the third dose was given and started doing a pan-retinal photocoagulation for this patient, but after the 2 laser sittings, it was really difficult to complete the further sittings, and the patient underwent a cataract surgery to get the clear media. By this time, the things were even better, and post-operatively, the further laser was done, and he improved to 6.9 and 9, and IOP came down to 18, but he was using 2 drugs. So though the disc was pale, but the things were better. The vascularization was going down and the retina was looking less fiery. And there were good laser marks to support both on a right side as well as the left side. So he was doing pretty well, but unfortunately, there was a recurrence and there was a further loss of vision, and this time the new vessels, they started at the angle also, and angle started closing at many places. So we did a 4th intravitreal injection and advised the patient to go for a surgery. But unfortunately, because of his uncontrolled sugar, and when he was in 2020 and 21, because of the COVID, the son was with the patient and they were coming for a regular follow-up. But unfortunately, after the COVID period, his things were not under control and son was not with him. So he decided to go further to son's place. And meanwhile, IOP kept on going high. It reached to sometime 40 and 32, and the pallor went on increasing. So we did given him a 5th dose of injection. Laser was supported so as to get buy some little time for the surgery because he was not medically fit. The BP, sugar, everything was uncontrolled with the nephropathy. And unfortunately, he developed a cardiac element in the March 22 for the cardiomyopathy, and ejection fraction went down further to 20% now. So now it has become a real problem because the things were progressing. The son was not at Bhopal and the IOP kept on increasing, and he was never medically fit for the surgery because of his cardiac element, and vision and IOP kept on fluctuating. And because of the macular edema, at times he used to feel very low in the vision, and with the intravitreal he used to improve. So even he went in between to the son's place, and then they got another laser and injection at Delhi itself. HbA1c was also fluctuating, the uncontrolled diabetes, nephropathy, and he was advised to go for an AGV but never got in fitness. And the things kept on progressing, and there were more of an optic atrophy which was developing eventually down the line because of the delay in the surgery. And things were not good, but he lost to the follow-up because every time he used to come and get the injection and promise me to go for a surgery, and unfortunately he never used to go for a surgery. whenever he used to get fit, he will say that, okay, I will go for a surgery. And whenever he were not fit for surgery, he will promise me that he will control the sugar, he will control everything and go to the surgery. But in the span of 1 year from 22 to 23, the things progressed badly. Even the epiretinal membrane started developing and he got never a good systemic control. And unfortunately, we reached to more or less a blinding, and with the right eye reaching to the hand movement in January 24 with a tractional retinal detachment and a big hemorrhage, which is covering the optic nerve, and the left eye showing a pallor, though he has 624 vision, some hope left. So now this patient is with Dr. Harsh Kumar sir for AGV, I suppose, at Delhi. And this is the left eye last photograph of the patient, very pale disc. So the lesson learned from this case is neovascular glaucoma is a potentially blinding disease, and there is an intractable secondary glaucoma with a devastating visual consequences. So we need to manage urgently with injections and PRP as well as glaucoma surgery, which was not done in this patient. So we should always rush for a glaucoma surgery. A delay in the glaucoma surgery for this particular patient was probably a major cause of vision loss. And we failed in reversing the rubiotic rampage due to the multidisciplinary problem in the patient, the adherence to the treatment, and especially the fear of glaucoma surgery. So we struggled a lot to control the systemic condition. Unfortunately, with the repeated efforts, we failed to control due to the multiple problems, and the disease progressed and lost the vision. Though with the appropriate treatment, 3 to 48% of such patients can lose vision, but definitely it is a serious sight-threatening condition we should be aware of. And the major problem was his cardiovascular event. So prevention is always better. So we should weather a storm of neovascular glaucoma in high-risk patients. Thank you so much for the patients listening.
Thank you, Vinita ma'am, for again highlighting an important point in when we talk about managing the neovascular glaucoma is the strong motivation for the patient, that he needs to be really motivated for undergoing any kind of procedure and the follow-up schedule. So we would again request MDA sir for his opinion and his comment regarding this particular case management.
I think Vinita has been trying her level best to do surgery in these cases. Of course, as we have discussed in the previous cases, surgery is the answer in these cases, whether trabeculectomy or a drainage device, whatever works better in your hands, as was said by Dr. Harsh Kumar in the beginning itself. So maybe in the case conjunctiva is available, is virgin, then you can start with trabeculectomy and later on go for GDD. But of course, without the control of diabetes and HbA1c14 and blood sugars always remaining above 200, doing surgery has its own risk and should be avoided. And of course, then the end result is like this. So we have to counsel the patient very well. So that's the lesson to learn from this case. Vinita must have tried her level best to counsel the patient well, and a multidisciplinary team has to work in these difficult cases, admit the patient in a general hospital, and the team should be formed formally to control. And these things are easier said than done. It is not always easy to get control of these cases, and of course, surgery is the only answer with the control of the systemic condition.
Thank you, sir. Harsh sir, what is your opinion? Sir?
I just remember I got a shock of my life when Vanita said that.
Now, sir, ball is in your court now, sir.
No, that bloody court is, that patient has come with finger counting close to face, not even finger counting, hand movement close to face. And the other eye is gone. So I said, what the hell have you been doing? And then he said, look at all these records, sir. We have been regularly following up. So now I get the whole picture of what has actually been happening. And and they had a doctor accompanying. So I said, kya karna hai? There's nothing much left. So he said, if you were in his shoes, then what would you do? Then I was really, really moved, and I said, okay, fine, go ahead. Then we will do a. And again, the conjunctiva was okay. So I said, I will try a trab. If I feel on the table it's not in, then I'll do an AGV. But we'll keep both the options open. But I would have already done it, but he had not stopped
Not
his blood.
stopped the equestrian. Yes, he
Huh.
only today
So
informed
probably,
me.
yeah. So probably today he had come to Dr. Lalit and then he had given it to me, and both of us were trying to force it on him, each other. But so ultimately, so anyway, this thing apart, yes. So we have to do in the end stages whatever we have to do best, whatever works, and I keep always both the options open for me. And if on the table I see that there is no NBI, I may just try out the trab also, because it's so much easier to do in these situations and much more control for us. Second thing is, uh, if and whenever, nothing to do with this case, but in general, I just wanted to say that if and when they are doing the retina guys are with you and they are doing a good vitrectomy, I must say that it is very well worth putting a posterior tube, because the past planar tube, like Kavita was also saying, the chambers are many a times shallow. And all of us have seen the NVG ultimately may just contract here and there, and the chambers may become shallow. The NVI may occur again, and if tube touches, then we are in a proper mess. So definitely, if they are doing a vitrectomy at that time, doing an endo laser with that, we must tell them to induce a PVD, do a full good vit, and put a posterior tube. I really love doing it now, and so many of our cases are doing very, very well. And you are just not worried about the AC and the cornea at all in these cases. And I would like to ask, because Shushmita gave obviously she keeps meeting everybody, but she said that nobody is doing the mito on their AGVs. And also, I'd like to ask Mona and the other people, Sushma, in their institutions, are they also not using any mito over the tubes?
So for the primary tube, we don't use mito, but like you said, when it's a encysted bleb over the plate, then when we excise the tenons, that time we do put those sponges in
Shall
the
we change
area.
our strategy? What do you say?
But even that doesn't work too well for a
Yeah,
long time.
it has not been found to be very effective, but what the hell? Anything which works for us will work.
But for a few months it works, and then again it's back to square one.
But I'm not sure, sir, that is the thing of the MMC. The fibrous capsules are so bad. Once it happens, I rarely see them regress. They land up with a second tube or maybe an ECP or something. You have to do
So
something.
that's what I'm saying, that should we do it
Yeah.
as a primary procedure so that these
Yeah.
things don't happen?
I know,
Because
I've
that's
done
what
it
we're
now.
doing. Huh?
So
Yeah,
I've done it now. So let's see.
I think there won't be any harm.
Yeah.
And another thing is that, which I obviously most of you know, I love putting an anti-VEGF in the bleb, and why not over there posteriorly? Because, and sometimes the cost is not the factor, because all of us have retina surgeons in the other room and they love giving 1,000 injections. So I always steal half of their injections, and that is enough for us. So I think we can try that as well.
Wouldn't that be transient, sir? I mean, by the time the capsule and the cyst forms, it's
No.
always
The point is, for 3 or 4 weeks, it keeps working. And like she said, that we are getting newer and newer ones which are working for a longer time. And it is for that time that the fibroblast movement and the neovascularization occurs at those areas. So there's no harm trying, I mean to say.
So I think we should also be ligating our AGVs and stop that inflamed aqueous going out. let the micron resolve over time, and
Can you
then
please explain to us how exactly, not the ligation, but this putting the thing in, ripcord. Can you exactly explain, you or Kavita, how exactly the ripcord is to be put and where it is taken out from and how it works?
So the ripcord, sir, we use actually, Kavita, I know the Supralon is now available, but actually the 3O nylon is so much easier to take out because it's monofilament and it doesn't entangle with the tenons. Sometimes the multifilament ones are little entangling. So
zero nylon, you're putting
zero
from
nylon.
outside.
Yes. So before
Make a hole in the tube.
No, sir. When the tube, where the tube is ending,
Okay.
where the fluid is coming out, we just put it into the tube from the back.
Oh, okay.
Yeah. So you just take the valve, or rather the plate, and just insert the tube from behind where the fluid would come out.
Okay.
And 3O nylon is nice and snug for the Adi. So
Okay.
you put it in and about halfway down and ligate on top of it. So what happens is when the ligature opens, it's a very
So
controlled.
will this not be enough? You want
No.
to ligate also?
Yes, because initially we wanted completely watertight and the ripcord is not completely snug and watertight. So the idea, sir, is that what happened was the ligature loosening is so unpredictable, and our hearts were in our mouth when to stop the diamox. Sometimes it opens at 5 weeks, sometimes it opens at 6 weeks. So we always start calling them weekly by the time it's about 4 weeks, because we used to be scared. Now with the ripcord in, whenever the vicryl opens, it doesn't matter. There is no hypotony so far. We've been doing it for about a year now. It has made our life so simple. And many times you don't need to take it out. The pressures remain all right. And if the pressures are high, it takes 10 seconds on the slit lamp and it just comes out with a small snip. Of course, with the children, we need to take them to the OR. But adults, it takes.
Cases you need sudden lowering, means the patient has come to you with 40. Many of these are guys who are on very high pressures and you need the lowering.
Yes, that is true. We sort of carry on with Diamox and glycerol and everything and tell them, you have to bear with us for about 6 weeks and do that. And we give venting stents. So hopefully it does come down a little bit initially, but that is there. There I agree that if you want it down fast, then it's a problem. But even now, Ahmed has come out with an ACP and they have a pre-placed proline. So they put in a 4O proline into it. So we don't have to insert it. It's already there. It's pre-placed.
I have a question. I mean, to all the experienced surgeons here. There was a patient actually with neovascular glaucoma, and the pressures were not. Patient was actually referred to the institute for DLCP. But on examination, I could see that he had counting fingers 2 to 3 meters of vision. So I thought, and he had already received an anti-VEGF injection elsewhere. So by the time I saw, after 3-4 days, his NVI had resolved, and cornea, even though the cornea was not absolutely clear, but he had a vision of CF 2 to 3 meters. So I thought we'll go for a GDD, and I would have he was on maximum medication and I was still uncontrolled. So I would have gone for an AGV because I didn't have experience with ADI till then. But that patient had to undergo an ADI because of financial problem. So that was my first case of ADI, and post surgery, the IOPs were really very high for the 42 days exactly. Actually, Dr. Ganesh had told me that if you ligate it with 60 vicryl, then it will open exactly at 42 days. So true to his word, it actually opened on 42 days only. And those 42 days, his IOP was too high, like in 40s and 50s, despite maximum medication. So should we go for valve GDDs in these cases?
Retained?
Yes, vision is retained.
So now
He is
we know
a
that
temple
after 40
pujari
days,
and he is
40
able
days
to
of
do.
40 pressure, the vision will be retained. That is great news.
I was really biting.
Did you put in the venting stents? That is what
Yes,
really.
yes, I had put, ma'am. I had put. Despite that, there was no way I could control the IOP for the 42 days. But after that, everything now is controlled and he has reasonably good vision. He can move around within his house and do the familiar works. So, I mean, in those cases, should a valved GDD be the choice? Because what do we do in the immediate post-op period when he's a one-eyed patient on top of that?
I may speak, these are the situations where I would prefer a valid AGV when I cannot afford to have like this pressures for next few weeks and one-eyed patients. Yes, of course, there is a risk of having more fibrotic capsules in these patients, but initial part, I definitely want them to save the vision at that point in time. So I would definitely err towards the valve implant. I'm anyway little more biased towards valve implant, to be frank. So any patient who is other eye is compromised and I'm looking at very high pressures, AGV is my first choice. And if at all I have to,
Sorry.
Yeah, just 1 second. Please, everybody, there are enough charitable agencies and there are people who are willing to give a lot of money. Okay, so I think you just have to tap the resources. I just was talking to Vinay that day. There are so many friends of mine who want to do so much charity. So that 14,000-15,000 should not be a problem from anywhere. And I think Shainur, you must also be having a trust by which.
No, actually, this sir, this patient could not afford any surgery. The institute paid for the RD.
So you can, if you cannot pay for this thing, you ask me, I will pay for it. Okay, no, I'm not joking. I'm really saying,
Yes.
because I do give charity here and there. So please, in such a case, in situations where it is like that, you ring me, I'll send you the money directly. But there will be more than enough rich people in your place. You just have to please work a little hard, find out those people. There are so many of them, and especially those whom you people have, all of you have operated. They are willing to, and especially the one-eyed people, they are willing to pay anything for other people to get well. So please make a register of those people. Okay?
I agree with Dr. Harsh very much. Yes. A lot of patients who are ready to pay, and I know the type of patient, the clinical features that you explained. So I think this type of patient, AGV, we are doing only AGV, and in such type of patients, especially one-eyed high IOP, AGV works really well. Of course, the chance of that fibrocapsular, after 3 weeks, whatever the pressure increases, usually we start with the this brimonidine beta blocker, this combination after 1 week, even if the pressures are under control. In our hands, it has really worked very well. In fact, we have nearly more than 70 patients only of NVG. When we have operated, we have done only AGV and they are working very well. Maybe 1 or 2 patients where the pressure has gone up, but on medications, pressure are very well under control.
So what
don't
about
have very long experience.
phase of, sorry.
Yeah, can I just complete this? Regarding the injection of mitomycin over the plate, the cases in which I have given injections over the plate at 1 week and 4 weeks, none of them have till now, I mean, it's not a very long follow-up, maybe 1 year or so. They didn't have any of them encapsulated blebs.
No, you
So I
inject
don't
it
know.
post-op?
Ma'am?
You inject the MMC post-operatively?
Post-operatively, ma'am. Intraoperatively, I have not used MMC in any of the valves, but at 1 week and again at 4 weeks, I'm injecting. And
how much do you inject then?
Ma'am, the same 1 cc, 0.1 cc, sorry, 0.1 cc.
All right.
So I haven't seen encapsulation in any, so I just wanted to know any experience. What is your experience, ma'am? Do you?
No, I've just put it into intra-op and I hope it will work. That's what it is, but I haven't usually used.
Post-operatively, is there no risk of
Are you using
MMC going into the anterior chamber? Shahinur?
Sir?
No risk of mitomycin C entering the anterior chamber by giving post-operatively injection?
No, sir. No, sir. We
It
give
is
it
you give
over
0.1
the
milligram
plate.
per ml or 0.2 milligram per ml?
No, sir. The 0.4 milligram, we dilute it, and then 0.1 cc of that is injected, sir. Actually,
0.4 milligram per ml.
0.02 milligram. Ultimately, the dilution,
okay.
0.02.
Okay. And you give it in the capsule?
Yes,
in the
sir.
bleb?
Yes,
So
sir.
it has never gone inside the anterior chamber?
No, no. I have, I think, nearly some 7-8 patients.
Is this an AGV or ADI? Which one are you talking?
AGV, ma'am, AGV.
The only concern there would be that it's an unligated tube and the capsule hasn't formed. That'll form at 4 to 6 weeks. So the only concern I would have is we are injecting something de novo into, I know there's a valve, but I don't know what MMC will do to that because there's no capsule to offer any resistance as yet. It's just virgin conjunctiva, that's all.
And also that patient Shahinur, as she was showing, they had issues with conjunctiva causing, the suture exposure and leak. Is that related to the MMC injections in that patient?
No, no. It is actually with the scleral patch graft which I had sutured with tenno nylon. I mean, it was just subconjunctivally. So after this case, I stopped putting the sutures that way. So that was because of the sutures only in the subconjunctival area.
Okay. And as we are discussing about the managing the intraocular pressure 6 weeks post-RD, so in my experience, when I do AGV also, the hypertensive phase is also like really depressing. Again, the pressure rises and starting the patient on medications like, that is also equally depressing as compared to the top, the 6
Not
weeks.
as bad.
One
Not
very
as
interesting
bad
thing
as ligated tube.
No, but if
Okay.
the pressure is not controlled on Diamox and glycerol
so,
pre-op,
sir,
then we wouldn't do it, sir. My signal would be if the pressures cannot be controlled on Diamox and glycerol, then I wouldn't put a non-valve because I know it won't be controlled after that.
okay,
But
one very interesting thing I want to share that some of these valves, like Kavita was saying, the moment the pressure starts going up, teach them how to do a massage from the opposite end.
Yeah.
I was so shocked that the pressures were coming really, really down. And once I guessed that the flow is maintained through this massage, and I thought I have discovered something new, but then I went back and read, then it is a very well known fact that not only in the trabs, but in the tubes also, the massage can be done very well. I actually didn't know it.
So
And
the
it is
massage you do it from the lower lid, like we do it.
just from wherever the tube is from the opposite side. So teach the patient to do it, make him sit, make them do it in front of you, see that the pressure is coming down, and the earlier the better, because when the steroids are on the higher side, the tubes are, the conjunctiva can be all, it really flows through, and the flow is maintained, then the things become okay.
From the house, so whatever tube surgery I saw today was using the scalar patch graft from elsewhere. But yeah, I usually do my tubes using the patient's sclera, using their own sclera. What is the take on the house?
So Sudhita, I am doing half of the sclera from the patient, and the rest posterior tube I cover with the donor sclera. Because, and that's a good idea because the sclera, the patients, one of my patients in whom we had to put the whole patch came, said that my girlfriend is really hating me because when I look down, I look like a bhoot. The white area was seen.
Correct.
So then I realized that it is better to have the normal sclera over there, at least
Yes,
surrounding that
absolutely
area.
true. So I usually do my tubes like that with the own patient's sclera. So that's it.
You can even use cornea. I mean, if you have corneas which are
Absolutely.
We don't have an eye. We don't have an
Absolutely.
eye
If you are
guide.
lucky enough to have corneas, then yes.
Yes, no, we have used all these things without sclera, without cornea, and with cornea, with sclera. All these varieties have done, and they all do equally well. The only thing is little cosmetic problem is definitely there with that sclera, but I think that's the most equal and simplest to do.
And some of my friends have started doing smile lenticules.
But I think that's very thin, Dr. Harsh.
That's what I told them. But 3 of them are doing it and they are very happy. So what can I tell them?
No, once they get it first exposure, then they will stop doing it.
Then they will know. Yes.
Just a question from the audience we got out of the several questions that carotid artery management, should it be done before the ocular surgery or should it be done simultaneously with the ocular surgery or after that? A clarity on that. I request the house to give the opinion on that as we are coming towards the end of the session. So this would be the last question, I
Let them
believe.
do the endarterectomy. If the patient survives, then you can do the rest on the eye.
If the pressures are high, then we need to manage pressures, and within endarterectomy can be done within 2 to 3 weeks after this.
Okay.
That is the right answer. I was just joking because Saturday night you have to make people laugh.
No, with that, we come to the end of the session, and thank you to all the eminent speakers, chairperson, panelists, everybody for joining us tonight. And I would request now Manoj sir to give a vote of thanks, a formal vote of thanks.
Thank you, Shweta. But we must thank you also and Mona.
So thank you very much, sir. Without each of you, it wouldn't have been possible for me to bring everybody on the same platform. Thank you, all of you.
And before we finish,
So-
Manoj, if you want, Manoj, if you want to make your name in history of AIOS, please provide free this thing, these this valves to people who cannot afford.
Okay, let's see how we.
Dr. Harsh, we are already providing the same, but the history has not got created yet.
Now, who is providing what?
Free AGVs to all the patients.
In Delhi?
Yes, in Delhi.
No, but Shainu doesn't know about it, na? So
We are providing to all the patients, and the government of India pays for it.
No, because Dr. Vinay Gupta in AIMS does not know that. He's been craving.
He knows, everybody knows in Delhi.
No. He just asked me that day. Anyway, Manoj, please go ahead, yaar. I'm sorry.
So, yeah, since we are coming to the end of the session, it is my proud privilege from the headquarters of AIOS to present a vote of thanks. My thanks at the outset go to Dr. Harsh Kumar for chairing this session. Then the three distinguished panelists, Dr. Chandrima Paul from Kolkata, Dr. Sushmita Kaushik from Chandigarh, and Dr. Manavdeep Singh from Delhi. They really contributed their insight into various cases, and I must say a diverse set of cases presented from all over the country. I could see a presentation from Arvind, I could see a presentation from Guwahati, I could see a presentation from Bangalore, and the other end from Bhopal. So an entire stretch of the country was covered. So my sincere thanks to all the speakers, Dr. Kavita Srinivasan, Dr. Shefali Parekh, Dr. Shainur Tayeb, Dr. Sushma Tejwani, Dr. Sudipta Ghosh, and Dr. Vinita Rabnadi for presenting a diverse set of cases and which elicited a good response and a good discussion from all the panelists. And last but not the least, a wonderful team of Dr. Mona Khorana and Dr. Shweta Tripathi. So I must say, when we offered this session to Dr. Shweta, she enthusiastically accepted, and within a day, she came back to us saying that, yes, sir, we are going to do this. And we had to literally advance this session by 2 weeks because we are preoccupied during that time, and we didn't want it to be too close to our AIOC. So well done, Shweta. Like you really handled this session very well. And I must really compliment you along with Dr. Mona Khurana for getting very, very interesting cases from all parts of the country. This is a truly Bharat seminar. So thank you, everyone, for your.
So much, everyone.
Thank you so much. Thank you, everyone, for the opportunity.
Thank you.
Thank you.
everyone.